in several different forums, and excited to share some of that with you all today. Some of this presentation, if you all have hung out with other presentations for me in the past, may seem familiar. Of course, I see a few names who've actually worked with me on some of our major deliverables and projects, manuscripts together. So, really pleased to see you all here, and I'm definitely going to give you all a shout out at some point in this presentation today, just to put you on notice. Um, but I think also, even for those, if you've heard me speak in the past, I've added some additional items here as far as just our experience at St. Thomas, and maybe taking a look to not only give you kind of this macro view of, the entirety of the state of the union, so to speak, but also just what I think is a really positive case illustration for us, our health system here in Tennessee. All right. And I'm a very interactive presenter. I love talking back and forth. Those are my favorite presentations. So please feel free to, add comments, make me stop talking, raise your hand, whatever it is we do in Zoom nowadays. Or if you're there in that classroom, just stop everything and feel free to ask a question if you've got it. So we'll go ahead and move forward. So first off, no relevant financial relationships with ineligible companies to disclose. Kind of our goals for this presentation today. First off, I want to make sure that we're all working off of the same sheet of music, and that means that we need to understand some common definitions and really maybe add some precision to some of the things that we talk about from week to week in our advocacy conversations. We're then going to do a little bit of summary around the State of the Union. I'm going to avoid doing as deep a dive as I've maybe done in other presentations so that we have time to talk about our own experience here at St. Thomas. But please feel free to put me on the spot and test my knowledge and memory of what is a very broad topic. I will not be embarrassed at all to get stumped. Um, but at that point, we're going to then kind of shift towards, okay, using this framework of this summary to translate that to show you how that works in real life. And some of the things we'll talk about, there's so many different directions. So if y'all have an interest in hearing more about payer enrollment versus what does credentialing and privileging look like from a peer review perspective, those are all things we have real live fire experience with at Ascension St. Thomas, and I'd be happy to expand on anything about our health system that you're interested in. And then really my hope at the end of this, every presentation ought to have a purpose. And I really want this presentation to be more than just informational. I want it to hopefully be inspirational to you, that it would inspire you to say, hey, this is really cool. Because of these things that have been accomplished in other places, or maybe even in my own state, what is that next step that we can take? And depending on where you're logging in from, whether that's, Virginia or Tennessee or New York, that may look different for you, but I have a little bit of an idea of how we might be able to work together as a profession to work as a catalyst for some of this work. So let's start out with the current landscape of where we're at with compensation for clinical pharmacy services. Really, a lot of this, at least for me, started with an observation. I don't think I'm alone in this observation. But that is that, you know, when we talk to pharmacists about what are the barriers we face between taking our knowledge and expertise and actually putting it into place, there are some commonalities that we've seen develop over history as to what those major barriers are. You know, I don't know, maybe 40, 50 years ago, maybe that question was insufficient training. We had a lot of changes that happened in the residency world, the PharmD curriculum, ACPE, to make sure that we have sufficient training. Other barriers that you might look at historically with scope of practice laws. I think last year we just made it to the very last state. And at this point, according to my colleague Ryan Wargo, we now have all 50 states in the union that have collaborative practice agreements or CDTMs or whatever term your state prefers to use. We have advanced scope of practices. So maybe 10, 20 years ago, that was a barrier, but it doesn't seem like that's really it now. Another barrier commonly cited is sometimes acceptance by other healthcare professions. And sure, you still get some clinicians who that, working and collaborating with PharmD may be a little bit foreign to them, or they may have some hesitance. But I think in a lot of our settings, at this point, our physician colleagues are growing up with us as residents. Our nurse practitioners are glad to have us on the team in a lot of settings. So I don't, the pharmacists I've spoken to, again, there are exceptions to every rule, but I don't know if acceptance is really our major barrier yet. And then finally, you might say, well, do the patients understand this? This is a great, goal of many of our professional organizations is trying to get public awareness out there to say, does a patient understand what a clinical pharmacist does, or specifically one in ambulatory care? Certainly, there's some opportunity to change our public perception there, but my experience has been, and maybe you can echo this as well, that once we start offering a patient and get that patient in the exam room, they love it, right? They say, hey, this was a missing piece of the puzzle that you are now filling, and I want more of it. So really my conclusion is that these aren't the biggest barriers. What I have found are the biggest barriers in advancing and implementing advanced pharmacy practices is really the payment. It's really the dollars. We have a lot of great institutions across the US where they may be investing dollars in pharmacist services from a mission or charitable framework. That's how a lot of services at St. Thomas got started, is that, we saw pharmacist care as part of our charitable mission for our ministry. Otherwise, we've seen many colleges of pharmacy, collaborate with their local health system to say, hey, we're going to provide these services here. But the barrier, the glass ceiling that we keep hitting is, well, I can't expand further without having the financial justification to do this. It's funny, our new resident graduates, they don't like working for free, right? And most of you all, I love my job. But I tell my kids when I come home and they ask me how my day was, I was like, well, they had to pay me to be there, right? And so I continue coming to work. This idea that if we're going to have a highly trained workforce with a specific expertise that we are implementing into the healthcare system, it doesn't work if there's not an exchange of value to say that we are bringing value as pharmacists to the patient's care, and that we should, we're not satisfied to give that value for nothing in return. And so that comes to the question of how do we pay for the pharmacists? And unfortunately, what we faced for many decades now is what I would call structural discrimination against pharmacists in reimbursement systems. We can get all hot and bothered about that idea, and it is frustrating. You can understand a little bit of the history of how things have changed, but with all of this change that we just spoke about in the last slide, the thing that has seemed to lag has been having pharmacists incorporated and included in these reimbursement systems in the U.S. healthcare system. So if we kind of say, okay, well, we have some existing standards of care, so to speak, around pharmacist reimbursement. A lot of times there's about three of these. There's a couple others that I'm not going to go into right now, but there's kind of three major places that we see pharmacists get cost justified, or we say, hey, this is an existing reimbursement system. But they all have really major gaps in care. MTM, started in the early 2000s as part of Medicare Part D. This was one of the first places where we saw specific payment and reimbursement recognized at a national level, to support the clinical work of a pharmacist going through a patient's medication list. Difficulty with it, though, is it's just one payer, Medicare. It's not even all Medicare patients, it's Part D associated. So if you have a patient with Medicare Part B, this is not a medical benefit. Pretty limited in scope. It's medication focused instead of disease state focused. And so implementing this, if you've ever, been in the hot seat of having to implement clinical services and reimbursement structures in a health system, it ends up being a very small percentage of your patients that you're trying to see that are eligible for this. It's just not sustainable. Value-based care. This is where a lot of us, maybe on the call, have really gotten our start, and especially as we have looked in the post-ACA years of saying that we want to pay for quality, not just quantity of care. When we've had these demonstration models like primary care first, this has been a great way to say, hey, if we add a pharmacist into the mix, can we improve the overall quality of the care we're providing? And hopefully glean cost savings from that's how we're ending up paying for this. But the limitation we often find in those kind of structures is that the investment's often capped. We have this much budget that we're willing to spend on pharmacists, and we're willing to test it out. But as we try to scale these these services up to a large and larger population, often our C-suite leaders are hesitant to expand, the overall salary budget on what they often deem soft dollars. It's not a one-to-one on their books to see this encounter that you had with this patient achieving this A1C generated this many dollars of cost savings. Certainly, pharmacist authors have tried to make that case of what that looks like, and there's some figures out there, but they're not hard and easy to validate from health system to health system. The other limitation with value-based care is that it's dependent on payer priorities, which is not, that's not a bad thing. We work with our payers, and that's part of the art of being a leader is working with all of your stakeholders at the table to say where do we have common alignment on priorities. But let's say that your health system, your community has a specific passion or mission around a disease state, let's say hepatitis C. Like we really want to invest in hepatitis C and add a pharmacist to this care here. If there's not a quality metric that's tied to a significant percentage of that weight on the VBC, you may have to make that argument for stewarding your pharmacist resources to say, can we support that disease state when it's not tied to our value-based care arrangement? And then finally, when we talk about at the federal level, right, and that's one of the main things we'll talk about today is understanding this federal versus state advocacy. At the federal level, we have been seeking to amend Medicare law or regulations, working through CMS, and we just unfortunately haven't had federal success to date. I remain eternally hopeful and eternally supportive of our professional organizations in that advocacy, but just the brass tacks is we haven't had any success to date. And so, really, one of the things that I've been passionate about now intensely passionate about has over the last 6 years, having this conviction that maybe we need a new therapeutic target. We have different drug classes for different aspects of a disease state or a problem that we're running into a pathology. And sometimes we find that we need to take a newer approach. And one thing from an advocacy perspective that I'm really passionate about is saying that when you look at where the majority of regulations and laws that affect the health system come from, it's not an insignificant amount that comes from the states. In fact, I don't know if you remember this from your pharmacy law classes, but the states are the ones who have the primary authority over the regulation of healthcare, and that's an extension of the police powers doctrine, which is drawn from the 10th Amendment. And again, maybe you didn't think that you'd be coming to a lecture today to hear about the Constitution, but just let me remind you what that says. The 10th Amendment says the powers not delegated to the United States, that's the federal structure, those powers not delegated to the federal by the Constitution or prohibited by it to the states are reserved to the states, right? So unless the Constitution says that the federal government must do this or the states can't do this, the default is to come back to the states. So why haven't we seen a lot of advocacy there? Well, for one, for a national pharmacy professional organization, it's hard to hit 50 moving targets at the same time. I always joke with my leaders that whenever we have 20 key performance indicators or clinical priorities, we have 0 clinical priorities, right? A priority is only something that you can do for 3 to 5 things at a time. There's no team that can effectively work on more than 3 or 5 items at a time. And so at the national level, we just have a limitation of how many states we can advocate for at once. We may say, well, we have the state pharmacy associations. Absolutely. But if you've worked in a state pharmacy association, often they have different priorities themselves from the members that they have. Some of our state pharmacy associations may struggle with membership. Advocacy has a lot of cost at the state level, and they don't have the resources that a lot of our national professional organizations have. That said, despite those limitations, if we were able to consistently work at the states, what we find in other advocacy issues, when you go and look at other healthcares, if you go healthcare disciplines, even if you look at non-healthcare items that were handled at the states, seatbelt laws are a really good example of this. There is a common way to establish standards at the national level by going one state at a time and building a critical mass until it becomes the standard countrywide. Vaccines, I'm sorry, I'm not even sitting here reading my own slides. Vaccines are another great great way of looking at this. Look at COVID and how, pharmacy really shown as the premier place to receive vaccines and the place for those implementations. That wasn't the case 20 years ago, right? That we did not have full, vaccine laws for every state like we do now 20 years ago. So, and that was something that was implemented one state at a time as far as scope of practice. Okay, so maybe I'm, convinced you that we should be looking at the states. Let's shift a little bit to talk about this idea of provider status. So, what does it mean to be a provider? We're seeing a lot of folks in the advocacy world starting to encourage us to lose the term provider. I'm not afraid of the term provider by any means, but what I find when I start talking on this subject is that it doesn't have the precision that I need it to. And that's because you'll find different pharmacists use that term in different ways. Sometimes when pharmacists talk about provider status, what they're talking about is an expansion of their pharmacist scope. What are you allowed to do from a clinical perspective? Can you give vaccines? Can you do a collaborative practice agreement to do GLP-1 management under an A1C? Can you do test and treat? That's scope. That's the what of what you're doing. It is the service you're providing, so you might understand why some people would call that provider status, but it really has nothing to do with payment inherently. It's just saying what you're legally allowed to do. Sometimes you'll come across a state where they say, "Oh, we have passed provider status," and what you'll find is that they made an adjustment in the codes of their state to say that a pharmacist is allowed to be a provider and is allowed to bill. But allowing someone to do something versus saying for sure it's going to happen are two different things. Some of those states have found that they got that pass and they just assumed things were going to move forward after that point. And the payers in their state said, well, yes, we're really happy for you that you're allowed to be able to bill us, but we're still not going to pay you. We're still not sold. Um, Perhaps what is the strongest version of what you might call provider status, and this is really the term that I'm starting to try to harp on and try to emphasize as what I think is the strongest, most effective measure for achieving what we're looking after, and that is non-discrimination protections. I think this is a really effective language for us to use because none of us are looking for a handout. None of us in the pharmacy world providing patient care are saying, well, I think that you should give me money in exchange for no value. What we're saying is to say we have reached in many states the ability to provide the same level of service as other healthcare professions. Payer A, you cover this CPT code for this other healthcare profession. Why not me? For example, the state of Tennessee says that I am legally allowed to see a patient and do an office visit, a 99214. My services fall within the AMA CPT definition of that code. And the state of Tennessee says that I, as a pharmacist, am allowed to do that. You cover 99214 if it's provided by a physician assistant, nurse practitioner, or physician. The only reason the mismatch here is that you're discriminating against me. You're saying that because of that license type, we don't pay pharmacists. There's no clinical rationale for there. There's no other rationale than the statement, you're a pharmacist. And so in 2017, Tennessee passed a non-discrimination law saying that you can't do that. If the state of Tennessee has said that Jonathan can provide that service and you cover that service for other folks, you need to pay Jonathan for that too. And so when you get into an advocacy conversation, or maybe you're introducing a new set of stakeholders to this, make sure you're using precision in your language so that everybody's singing off the same sheet. Um, just one last note. Another thing that I'll see from time to time is advocacy for a new code, to say, well, pharmacists have something unique and special that other healthcare professionals don't have. And this is true. We do, I would say that we are a unique member of the team. But I would add caution because if we have our own unique set of CPT codes, then those can themselves be regulated in a way that may continue that discrimination. In my opinion, it's not necessary, especially after the 2020 revisions that were made to the medical decision making. All of our services are very well described by the existing set of office visit CPT codes, the 992 series. And so instead of creating a new payment mechanism, I think the argument is simpler just to prohibit discrimination by license type. So what does this look like? Well, there's two places I'm going to give you an example for. The first is at the federal level. Oh, wait a minute. Did you know that there is federal protection against non-discrimination? Is it well implemented? No, but the language is there. In fact, I'm about to show you Tennessee's law. You're going to see something that looks very familiar, and this is something from the Federal Register. This is a federal rule against Medicare Advantage plans. It says a Medicare Advantage organization may not discriminate in terms of participation, reimbursement, indemnification against any healthcare professional who is acting within the scope of his or her license or certification under state law solely on the basis of the license or certification. Even for people who know a little bit about this topic around advocacy at the state level, a lot of them don't realize we already have that language in the federal level. There's just some mismatches on the implementation, and that's one of those optional, choose your own adventure. If you want to talk a little bit more about why that is, I'd be happy to chat about that and what we've been doing about it here in Tennessee. So here's TCA. This is the Tennessee Code annotated. Like I said, you may notice some inspiration from the national language here. It says the managed health insurance issuer shall not discriminate with respect to participation, referral, reimbursement of covered services, or indemnification as to any provider within a class of providers who's acting within the scope of the provider's license or certification under state law solely on the basis of the license or certification. That language wasn't new. That's not what got changed in 2017. What got changed in 2017 is they added pharmacists to that list of protected providers. These providers, that class of providers up here, now includes pharmacists in the state of Tennessee as of 2017. Again, this is very simple. This is not saying I want you to create some new mechanism or I'm just going to expect to do whatever I want as a pharmacist and expect you to pay me what I said. This is just saying, hey, treat me like everybody else. If my state says that I'm allowed to do some of the things that other people are doing, and you already pay for those, don't discriminate against me just because I have a PharmD behind my name. So my thesis, and at different times over the last decade, I felt like the unpopular guy in this Norman Rockwell painting. But my thesis is that so long as fee for service remains the predominant mechanism for provider reimbursement in the U.S., pharmacists should pursue access to this payment strategy. I am completely open to bigger picture conversations about is fee for service the best payment mechanism? Does it achieve what we want to in U.S. healthcare? Totally get it. I'm also not advocating that we get rid of other payment mechanisms. And one of the parts of our story at St. Thomas that I'd be happy to chat with you more is how we have incorporated different payment mechanisms. I have value-based care contracts that my pharmacists contribute to. I am not saying that we need to abandon other models, but what I am advocating for is that so long as fee for service is the major way that providers get paid in the US, we don't need to leave ourselves out of the table. All right, so one final observation. I had this observation, man. Let's see. Oh, yeah, this is the meerkat picture. I worked really hard, and I'll tell you a little bit more about this later in the presentation, but I worked really hard from about 2018 to 2021 to get our health system to this point of having sustainable billing practices under our non-discrimination laws. And, I had my head down, just battling month in, month out. And after we kind of cleared the smoke and we're starting to have some success, I started, like this meerkat popping my head out of the ground saying, where's everybody else? This is what I've been working, it's what Tennessee's been working on. What's going on in Kentucky? What's going on in Alabama? I met Ryan Wargo at an ACCP meeting, and Ryan, I heard him talk, and I was like, dude, I've just been doing all this stuff in Tennessee. I wish I had met you 2 years ago so that we could, I didn't have to reinvent the wheel for some of these things, or I would have benefited from that tip that you shared in this presentation. So that kind of pawned this question of where is everybody? If we're going to do a state by state, advocacy effort or advocacy drive, we kind of need to know where everybody else is. that became the inspiration for one of the biggest professional endeavors I've ever undertaken, and that is what we've called lovingly the State of the Union manuscript. And so it's about 2023, had this idea and proposed it to the JACP editor-in-chief, and had that accepted as an invited manuscript. And I think this is also a great story of how sometimes your first implementation or iteration of that idea doesn't go well, and you just need to not give up on that. For about a year, I tried to implement this with a small co-author team, and what we found is that we were all really busy. And we all had jobs, right? And the jobs were busy. And trying to wrap our heads around as a 5 or 6 person author team over 50 different states and all of their massively different regulations and legislative, where they keep their laws and things, their statutes, that was going to be too much for us. And so in the fall of 2023, I said, well, what if we made this a large author group? And we had some concerns about what that would look like. But I just said, I went home. This was after the ACCP meeting in 2023. I went home and I just said, I'm just going to ping people that I know at this point. I know a lot of people through the ACCP AmCare PRN, met some great folks, at the meeting. I'm just start emailing them and say, hey, I have this idea. Would you want to join? And before the end of the year, we had so many people who said, yes, let's do this that we were able to kick off a major collaboration of more than 40 authors in 2024, ultimately resulting in the publication of a beautiful manuscript in July of that year. This is the original paper that we published. We published this under the grouping of the Advancing Pharmacist Payment Parity Work Group. That work group has now grown substantially. We just underwent a very major revision to the State of the Union manuscript that was published about 6 months ago. It was submitted 5 months ago. It was April, so that'd be 4 months ago that it was published online. That team has grown to 61 authors. And so I don't know if you've ever tried to work with 61 people to do anything, but that's a minor world wonder that we were able to pull that off. But these are the really amazing pharmacists who contributed to that work. And I'm very grateful for. And as I mentioned, I see a few of you here on the call. I think I saw I see Starlin, I see Sarah. Man, I'm sitting here trying to click through all the attendings. I'm sorry if I've missed somebody here, but yeah, I'm so grateful to this group of authors. Like I said, it's one of the proudest professional endeavors I have. But for this manuscript, what we set out to do was really three things. We wanted to do a narrative review for each state, where each state got the opportunity to tell their story of what statutes and regulations they had put in place or they had in place around reimbursement for clinical pharmacy services. We then wanted to systematize that and have a table where you could sort and filter and compare and contrast certain characteristics of those regulations and statutes, one to one in a centralized table. And then finally, we put forward model legislation uh, characteristics. We wanted to be careful to leave the language flexible, given the differences in states and what sometimes one state has political capital to do that another may not. And so we instead described characteristics. We said, okay, of all of these statutes that we've reviewed, what's the best of the best? Like what seems to be working the best? What's the strongest? We put together those characteristics. Here in our most recent publication in 2026, we replaced that section with some of the trends we had seen in the intervening 2 years and where we needed to go and continue to progress. Some of our latest findings, I mentioned 61 co-authors. We found 43 states that had something on the books. It may not have been a huge thing on the books, but there was some provision for payment or reimbursement in either the statutes or the regulations. So 43 states, I hope that if you don't know about this topic already, if you weren't on the manuscript, I hope that number encourages you. That's more than 80%. Sorry, math was never my forte. Sometimes I joke that that's why I went to ambulatory care because I can't do all those meg per kilo conversions. So yeah, 80%, more than 80% has something on the books. And then when we start coming to those stronger non-discrimination mandates or other mechanisms that provide for broad payer coverage, we have 17 states as of earlier this year that have broad commercial coverage requirements. And then six of them have narrower scope of service payment systems. And within the Medicaid system, so those are our two major non-Medicare payment systems, right? Medicare, that's got to be handled at a federal level. But for the things that we can affect at the state level, we've got commercial and Medicaid. For Medicaid, we've got 22 states that have enacted requirements that provide for broad payment parity. And 19, an additional 19, have some level of payment parity or reimbursement for a narrower scope of services. So that's majorly encouraging. Um, I just realized as I was logging on that I didn't include one of my favorite graphs that I've made in the past year, and that is I've got this beautiful graph that has the x-axis of the years over the last 20 years. And on the y-axis is the cumulative number of states that have enacted these non-discrimination or these broad payment parity provisions. And it's really cool to see where we are almost at what I think is a tipping point, right? If you define the tipping point as the place where the majority of states of our 50 in the union have enacted this kind of reform, we are just touching up at that point. And so it's a very exciting time to be talking about this topic because we're getting close. Now, the difficulty is maybe better displayed by this graph that you are seeing. The difficulty is that the details, the devil's in the details, right? And so the payers that are affected by these vary widely. If you look at this legend over here, the purple are states that have enacted both broad commercial and Medicaid coverage. But we've got other states that have only enacted broad commercial coverage, or still other states that have only enacted broad Medicaid coverage. And sometimes they have, one but not the other. They have narrow coverage, and so there's this hodgepodge of these states, and that's where having some expertise at the regional level and the national level, and having the resource of this manuscript becomes really useful when we're trying to drive advocacy efforts around a specific state. So, coming to the end of what I want to talk about from the big picture of the U.S., some key takeaways so far for you to consider is that evolving alternate, skip that first one. Although collaborative practice exists nationwide, we really need to be pushing for payment reform at the state-based level. And gosh, if I can leave you with just one thing from this presentation, it's that we're reaching a tipping point. We now have dozens of states with laws supporting pharmacist reimbursement and new legislation in 2025. And gosh, now we're getting to the point where a lot of the 2026 legislative sessions have connected. I haven't even had a chance to review those. We're continuing to push for momentum towards broader commercial and Medicaid payment reform. And our hope is that as this becomes the standard of care, that makes it easier for our professional organizations to advocate for us at the federal level to say, hey, we want our nation's Medicare patients to receive the same level of care that our nation's commercial and Medicaid populations are receiving from pharmacists. I don't know if we want to do some self-assessment questions here. I guess that's a question I should have asked you VCU folks before I got on here. Do y'all usually do self-assessment questions? If the answer is no, I'd rather spend our time talking about something else.
We can pass on those.
Okay, great. I couldn't remember if this was CE accredited or anything. Okay, so let's talk about our story here at St. Thomas. So, gosh, I put this together here real recently. It's such a whirlwind of thinking through the history of what we've done over the last, gosh, decade almost. Just want to tell you a little bit about our story. We've had a clinical pharmacist in ambulatory care since 2005. Um, Her name's Rebecca Hopper, and she is really a pioneer for ambulatory care pharmacy in Middle Tennessee, outside the VA. There's another pharmacist, Condit Steele, as Belmont faculty, and I don't know if any of y'all ever had the opportunity to meet him, but getting to hear some of his stories from really starting ambulatory care before it was a recognized known entity nationwide was really inspiring. And he's been passed away for a few years now, but I had the honor being the manager at St. Thomas to say that he was one of the original pioneers of our health system. But all of those services that were established before 2017, they were pre-CPA. A lot of times, and this isn't going to surprise some of you on the folks, but before we had collaborative practice agreements or CDTM agreements, we had to go we had to beat around the bush to implement some of the plans, either trying to get the provider to implement our plans after we've made that, or, sometimes acting as an agent of the prescriber, these other ways. And sometimes hospital protocols allowed us to do things additionally. But also, there wasn't really any billing. When you look at the total FTE that we had at St. Thomas up until 2017, we had two. We had one FTE, it was a full-time St. Thomas associate, and we had a couple of part-time shared faculty with some of our local schools of pharmacy. 2017 was a big year, and it wasn't just because that was the year I was hired. That is the year I was hired, but the big deal is that that was the year our CPA regulations were released. We did pass our statute in 2014, but a lot of health systems were hesitant to implement them until we had regulations from the Board of Pharmacy. So that was a big year when a lot of health systems we got that regulation, we could start implementing. From a legislative perspective, it was an even bigger year because that was the year that we had our non-discrimination mandate passed. We also had a Tennessee, a TennCare, our Medicaid program in Tennessee is called TennCare. And they had actually created a requirement for the MCOs in the state of Tennessee to have an MTM pilot for all of their patients who met certain criteria. Well, I got hired in 2017. I was fresh out of residency, trying to prove myself, earn my CPA, show that I had an impact on clinical metrics. We also were very siloed as pharmacists at that point. Really, as a young practitioner myself, got to benefit from learning from some of those more seasoned pharmacists. But our day to day, we had different reporting structures and we were geographically diverse. We just didn't really work together. From a billing perspective, that period, what we did work on was the MTM pilot program. And as I look back on that time, I really wish that I had not focused on that so much. The non-discrimination mandate part of that was the big fish that I should have been frying. But it was also the vaguest one. It was the hardest one to understand. When I tried to talk to my own leaders and people in my own hospitals or health systems billing department, it was the one that they didn't quite have their mind wrapped around. It took me a while to develop the language around that piece. Whereas the TennCare MTM pilot was very, first the pharmacist does this, then they're going to access that system. Here's the payment. It was very protocolized, and the details have been thought out by some of the advocates for it. And so, that was where we ran to it first. It turned out that unfortunately, some of those same problems we have at Medicare Part D MTM followed us into that Medicaid space, and we were only getting payment for a small sliver of our patients, even among the Medicaid population. And so, really, when I look back at that, I kind of regret and wish that I'd spent more time on the non-discrimination piece. Maybe we could have gotten things moving a little faster. But everything in its time and season. I think y'all mentioned that I'm a residency program director, and that may seem like that's an aside, but actually it's a critical part of this story. Is that in 2020, I was able to bring on my first PGY2 ambulatory care resident. And what we did in 2021 was that we had collected enough momentum, discussions with payers about what non-discrimination looked like. We had done some test claims over COVID. So many stories and funny conversations I can share with you there. But we utilized our resident managed clinic to be the first place where we flipped the switch to say, this is the standard of the model now, to where we bill all patients, all payers, no matter how they come in. Of course, we had to figure out how to implement Incident 2 into that. That's a whole nother conversation. But we had a exceedingly successful billing pilot at our residents managed clinic, such that with that success, as well as some primary care first grant funding, St. Thomas approved 2 additional FTEs to be hired that year. So I was really excited to keep on that first resident and bring another pharmacist in as well. The next year, we were able to add a 340B funded rural health pharmacotherapy clinic. So, kind of going back to that point that I'm not advocating that fee for service is the only revenue stream that we work on. I am 100% pro multiple revenue streams, and we have done that. We have walked that talk here at St. Thomas. Um, as we moved into 2023, we started kind of seeing this tension between this idea of, are the pharmacists providers? How do they interact in the systems? What kind of support do we give to our pharmacists from an auxiliary personnel perspective? Some of our pharmacists were lucky to have an MA that could support them in their practice, but others were not. Resources were stretched too tight in that clinic to where there wasn't any MA support for that pharmacist. And we felt that internally. I regret it, but I lost a couple of pharmacists during that period because of that tension. So we went through a major team redesign or team model redesign in 2023, where we were thankful to have another grant we were able to use to hire some pharmacy technicians to embed in our primary care practice. We also revised our pay and benefit structure that recognized that, hey, if this pharmacist is doing a really great job at blowing up their clinic volume and bringing a lot of patients in there, we're going to recognize that in our pay and benefit structure. So that was a major turning point for our young pharmacy service. We're still young, but even younger back then. In 2024, we got our first cardiology PharmD position approved. Historically, we had all been within primary care. I guess that's another point of pride is that in 2023, no, sorry, it was 2022, we achieved 100% primary care coverage. Every one of the 18 primary care clinics we have spread throughout Middle Tennessee had a pharmacist assigned to it. May not have had 100% penetration, but if a provider in any one of our primary care practices said, I want a pharmacist to help me with this patient, I had somebody who they could help, or who they could turn to help. So in 2024, that was a major accomplishment for us of moving and exploring a new service line. That continued to expand in 2025, where that pharmacist was so popular and in such high demand, it was pretty easy to build a business case to hire on a second cardiology pharmacist. We also started neurology specialty services and added a pharmacist to our team that way. And this year has just continued to be, man, just a sprint. It just seems like our team continues to grow, and I'm so thankful and feel very blessed and fortunate for that. But we've gotten a third cardiology position we're approved for, and by the way, I'm recruiting for, if any of you all know a cardiology pharmacist who wants to move to Nashville, Tennessee. We added women's health services through one of our shared faculty partnerships. And then we have a really major expansion of our pharmacotherapy clinic, the one that's rural health based, where we're adding, that says 4 additional FTE, but it's really 2 PharmDs and 3 technicians to our team, to where we now have a team of over 20 pharmacists and technicians who work here. And yeah, gosh, we're not trying to build any kingdom here at St. Thomas. That's not why we come to work every day. And a lot of our conversations, gosh, especially as I go to this next slide, can sound like, the goal of all of this is revenue and the profit there. But within St. Thomas, this isn't unique to St. Thomas. Y'all probably heard this statement, but no margin, no mission. Our mission is the primary thing, right? Providing that care to the entirety of our population, even those who are underserved and vulnerable. But without that payment structure to drive that, without that margin to drive those investments, that care for the community, we're just not able to. And so when I see this list here, I know that I'm accounting it with the numbers of FTEs, and that sounds very managerial of me. But what I really see growing there is that we're touching more patients' lives. This is a fun map I put together of all of the places that our PharmDs have responsibility for. Not all these places have physical pharmacist presence. Some of this is virtual. But we have pharmacists who are impacting lives throughout the Middle Tennessee region. And largely that's because we have been successful in making that cost justification argument. So some fast facts as we kind of near the end of our presentation here. Fiscal year 26, we were able to generate over $1.2 million of fee-for-service revenue. I have been dying to find some quiet time in my life to where I can write up this and get this published, and kind of show some more of the details of what this looks like. We had over 23,000 work RVUs for any of y'all who are familiar with that. For those of you who are familiar with it, though, I have to immediately warn you that that's an underestimate, though, because keep in mind for our Medicare patients, we're restricted to incident to billing. And so that 99211 there is going to be a significant underestimate of the actual productivity and the time spent by the pharmacist. We had nearly 14,000 PharmD encounters in fiscal year 26. So you can do the math of what that looks like per PharmD per month. But all of those productivity metrics, all of those financial metrics, again, I keep on coming back to this. That's not the point, right? We are a healthcare system. We are a ministry. We see that as our life purpose, a calling on us, something noble. What those things in the first three bullet points do is they allow and enable the second two bullet points. And that is that we have seen clinically and statistically significant impacts on our A1Cs and hypertension metrics. We have seen sustained improvements in our value-based care arrangements that we've taken ownership, in particular the statin use in persons with diabetes. And just to give you a little flavor of what that looks like without this becoming a clinical research presentation, um, we are utilizing those productivity and financial successes to drive real patient impacting, life changing differences in their patient care and their outcomes. So, call to action, kind of bring it to a close here. I mentioned at the beginning of this that the advocacy arms of our large professional organizations are national by nature, and it's hard to focus on 50 different states. But our states have a different set of limitations that they struggle with. So one of the things that I am advocating every time I get the opportunity to speak at this national level forum is for us to not work in a vacuum, right? That was this whole aha moment in 2023 when I had the idea for the State of the Union manuscript to say, I am not the only person working on this. Ryan Wargo is not the only person working on this. Sarah Amring is not the only, Starland is not the only person who's working on this. We need to come together, and maybe at the national level of working on this is not something where we need our national professional organizations to kind of train their cannon fire. Maybe we need to add an in-between level of organization and advocacy, and that might be at the regional level. And so the idea for regional advocacy might to say, okay, within my region, this map here is completely arbitrary, right? I just some suggested ideas of where are regions that are somewhat similar in geography and political culture and other culture, right? But the idea of this regional advocacy would say identify within that region who are the state champions, who are the ones who really, have been able to implement some strong successes, and then work with pharmacist advocates within those regions to conduct gap analysis to find a state that has opportunity to progress that. And then prioritize maybe one of those states every year to see if we can move that forward and say, let's just do this one state at a time. And that's how we can achieve national success is bottom up rather than top down. All right, so we're not